Good evening and welcome to this evening's webinar titled Pancreas Disease in the Black Community Towards a Personalized Medicine Experience. We're pleased that the National Pancreas Foundation and the Precision Medicine Coalition is co-hosting our webinar this evening. We'd also like to thank Elevation Oncology for sponsoring this important webinar focused on precision medicine in the Black community. Before going into our program, I just want to spend a minute or two talking about the National Pancreas Foundation. The National Pancreas Foundation is a 26-year-old national charity and the only charity in the entire United States that impacts all forms of pancreas disease, including pancreatic cancer, pancreatitis, pediatric pancreatitis, and FCS. We're really proud of the fact, meeting the NPF Board of Directors and our NPF staff based in Bethesda, Maryland, to have impactful programs impacting all patients, clinicians, and researchers regarding pancreas disease. A couple of the initiatives I wanted to mention is a focus of NPF this year and the next couple of years. And the first initiative is a Black African American initiative focused on access to healthcare and health disparities for the Black African American community regarding pancreas disease in the United States. About a year and a half ago, we launched a healthy eating cookbook, and still on a consistent basis, we're receiving 10,000 downloads a month for this state-of-the-art cookbook. We're about to launch a mental health initiative for patients, caregivers, and family members just to help support the burden of pancreas disease within the family structure. One of the things that's an asset, not only to our clinical and research community, but as importantly, our patients would be 160 medical centers of excellence throughout the country. Half are pancreatitis, 40% pancreatic cancer, and the other remaining medical centers of excellence, pediatric pancreatitis centers. The reason why we have these accredited centers is so our patients throughout the United States can go to a center to treat their pancreas disease and have the best outcomes possible. So for further information regarding the National Pancreas Foundation, you can go to pancreasfoundation.org. And with that, I would like to introduce the CEO of the Precision Medicine Coalition, Faswilla Sampson. So let me turn it over to you. Thank you.
Thank you, David, and I'm delighted to partner together on this valuable educational series today. I'm coming from the Personalized Medicine Coalition as Chief Operating Officer, where I lead a patient-focused personalized medicine education initiative, More Than a Number. And as background, the mission of the PMC, which represents innovators, scientists, patients, providers, and payers, is to promote the understanding and adoption of personalized medicine concepts, services, and products to benefit patients and the health system. At the Coalition, we define and frame personalized medicine as an evolving field in which physicians use diagnostic tests to determine which medical treatments will work best for each patient, and use medical interventions to alter molecular mechanisms that impact health. By combining data from diagnostic tests with an individual's medical history, circumstances, and values, healthcare providers can develop targeted treatment and prevention plans with their patients. I think it's worth noting that to achieve health equity and better patient outcomes, it's imperative to address this through integrating the voice of the patient and patient engagement efforts like this webinar today. Although the number of personalized drugs with biomarker strategies on their labels in the United States has grown from just 5 in 2008 to more than 300 today, complicated policy challenges and clinical adoption obstacles continue to make it difficult for healthcare systems around the world to capitalize on groundbreaking science and technology that point to a new era of medicine that for the first time promises to put the individual at the center of care. And yet, in a study, we found that 66% of adults living in the United States say they've never read or read anything about personalized medicine or precision medicine. So with most health consumers still unaware of what personalized medicine is and why it matters, patient-facing educational efforts like these are needed to prompt more point-of-care conversations about molecular targeted treatments and ways in which various medical interventions can alter patients' lives. The More Than a Number initiative intends to address this educational disconnect through broad consumer education using online or digital resources about what it means to personalize healthcare. We see there's an obvious link between taking patients' unique medical history, circumstances, and values, and healthcare providers working with their patients together to develop targeted treatment and prevention plans that are equitable. Personalized medicine, after all, is grounded in the understanding that people are different and thus need treatment and healthcare solutions that are unique to their particular needs. So I'd also like to thank our sponsor, Elevation Oncology, for their support of today's talk, and a huge thank you to our expert panelists for sharing their knowledge and insights. I'm excited to hear from each of them and to learn more about the promise of achieving personalized medicine experience. And with that, I'll hand it back over to you, David, to introduce Dr. Conwell.
Thanks, Faswilla. And it's my pleasure to introduce our first speaker and moderator, Dr. Darwin Conwell. Dr. Conwell is a great friend of the National Pancreas Foundation, but more importantly, one of the best clinicians in the field of pancreas disease in the entire country. So, Dr. Conwell, thank you for being with us. And Dr. Conwell is a professor chair in Department of Internal Medicine and the Jack M. Gill Endowed Chair in Internal Medicine at the University of Kentucky College of Medicine. Again, Dr. Conwell is a longstanding member of the National Pancreas Foundation Board of Directors. So, Dr. Conwell, let me turn it over to you.
Let me unmute. Can you hear me? Yes. Thank you very much, David, for allowing me to speak. And we're really excited that you are here for this webinar. I'm going to speak briefly on pancreatic disease in the Black community and give us just an overview of where we think this initiative is going. So as stated earlier, we want to welcome you. We're glad that you are here with us today. The NPF has created a pancreas disease early detection and awareness campaign with a focus on pancreas cancer and pancreatitis in the Black and African American community in the United States. So we're very excited and thrilled that you are with us today. I'm going to give you some background information on pancreatic disease to frame our discussion, to level the playing field and get us all in the same space in terms of understanding pancreatitis and pancreas cancer. So the pancreas is an organ in the upper abdomen, approximately 6 inches long. It's located behind your stomach internally, and this is what the pancreas actually looks like. So the pancreas really has two main functions to help you digest your foods. It secretes enzymes. It also helps you regulate your blood sugar levels by secreting insulin. So there are specific cells in the pancreas that achieve these functions. And when someone has damage or problems or inflammation, such as acute or chronic pancreatitis or cancer, these cells become dysfunctional and abnormalities can occur. So acute and chronic pancreatitis affects around 500,000 adults and children each year in the United States. This graph is one on the estimated new cases of pancreatic cancer, and there's 50 to 60,000 cases per year. It's more prevalent in males. You see here around 30,000 as opposed to females around 27,000. So this is not an uncommon disorder, an uncommon disease, and that's why we're speaking to you about this today, because we want to do everything we can to keep patients from developing pancreatitis or pancreas cancer. If you do get those complications, we want to make sure you get the appropriate treatment. It's important to know there are risk factors, and a lot of these risk factors are modifiable. If you're overweight and suffer from obesity, you're at an increased risk of pancreatic problems. If you smoke, if you already have diabetes, if your eating habits are unhealthy, and some patients, unfortunately, are born with genetic disorders that predispose them to bouts of pancreatitis and increases their risk of pancreas cancer. But this initiative is really meant to help you learn about the signs and symptoms, treatment options, and lifestyle changes that we would like for you to make. I'm going to briefly go over the three main pancreatic diseases we're going to talk about today. One is acute pancreatitis. This is a serious condition where the pancreas becomes acutely inflamed. This causes a lot of abdominal pain, and you would need to go to the hospital to treat this. And the people that have had this understand that this is requires pain medication to help control some of the discomfort that you have. The most common cause of this is gallstones or alcohol excess. Smoking also contributes to the severity of the pancreatitis. Other causes of acute pancreatitis besides gallstones and alcohol may be a medication side effect. Some of the medications that are developed now can induce a bout of acute pancreatitis. High cholesterol levels, specifically a high triglyceride level over 1,000 in the blood, will predispose you to having a bout of acute pancreatitis. High calcium levels in the blood can also induce this. Tumors of the pancreas, and as I mentioned earlier, alcohol consumption, usually a heavy amount of alcohol consumption. Now, chronic pancreatitis, which is different from acute pancreatitis, is when the pancreas begins to scar, where scar tissue starts being laid down because of the acute inflammation. Over time, there's irreversible damage, and we start having damage to those cells that secrete the hormones and cells that secrete the enzymes. And when we start having damage and loss and scarring of the cells that secrete the enzymes, you can end up with diarrhea and fat malabsorption called steatorrhea. We also can have damage to those insulin secreting cells from the scar tissue, and you can have high blood glucose levels, and of course that's called diabetes. Causes of chronic pancreatitis, there is overlap with acute pancreatitis, but there are some autoimmune conditions that predispose you to chronic pancreatitis, and your physician will know about this. And if you're not sure, definitely go to an NPF center of excellence throughout the country. Genetic mutations can also lead to this, and genetic testing is not uncommonly done in patients that have pancreatitis, and we don't know the cause. Cystic fibrosis, you're born with this, and this is seen a lot in our children. A blocked pancreatic duct from a tumor. Pancreatitis can run in families, and of course heavy alcohol and tobacco use again can make this disease much worse. Now, pancreas cancer overall, just cancer in general, in the United States, Blacks and African Americans bear a disproportionate share of the cancer burden. And we actually, African Americans and Blacks, have the highest death rate and lowest survival rate of any racial or ethnic group for most cancers in the United States. So pancreas cancer is when you have malignant cancerous cells in the tissue of the pancreas. And we know from National Cancer Institute data that Black Americans are more likely to get pancreas cancer than any other racial or ethnic group, and they have the highest incidence rate of pancreas cancer in the United States. Now, I want to show you some more data on pancreatic cancer and how it's broken down in terms of racial and gender differences. I think the color coding helps a lot. The blue line represents Black males and represents, the death rates for Black males. The orange line represents Black women, Black females. The green line represents white men, and the red line, white women. So if we look and compare the blue line, which is Black men, to the green line, which is white men, we see a markedly higher death rate in Black men versus white men. When we compare women, and we see Black women represented in this orange line and white women represented as a red line, we see also a disproportionate higher death rate in Black women versus white women, as seen in Black men versus white men. So this is the awareness that we want you to have. This is why we're spreading the message today and throughout the country. What should you know about pancreas cancer? You can have digestive problems when you have this, abnormal bowel movements, nausea, vomiting. You can get jaundice where your eyes can turn yellow. A lot of abdominal pain, loss of appetite, and severe weight loss. And some patients can develop diabetes when they have pancreas cancer. There are risk factors for pancreas cancer, very similar with overlap for pancreatitis, acute and chronic pancreatitis. Smoking is the most preventable cause of pancreatic cancer. I want to repeat that. Smoking is the most preventable cause of pancreatic cancer. So if you smoke, if you stop smoking, that markedly lowers your risk of developing pancreas cancer and also a lot of other cancers. Obesity is associated with diabetes that predisposes you to the development of pancreatic cancer. Diabetes in and of itself, adult onset diabetes or type 2 diabetes predisposes you, is a risk factor for pancreatic cancer. We also know if you have acute pancreatitis and have recurrent attacks of acute pancreatitis, eventually the gland begins to scar and you develop chronic pancreatitis that predisposes you to pancreas cancer. Now, one important phenomenon that we want to talk to you about are social and environmental factors that may contribute to your health care and that may impact your outcomes. And these are called social determinants of health. So social determinants of health are non-medical factors that influence health outcomes. There are conditions in which people are born, grow, work, live, and age that can impact your outcomes and your access to healthcare, your morbidity, your mortality. You know, if you have economic instability, if you have a problem with access to healthy food options, like we talked about before with obesity and development of diabetes, that can impact your outcome in pancreatic disease. And that's the reason why David mentioned earlier that we have a cookbook that you can download, and there are a lot of downloads for that cookbook. Where do you live? Do you have a place to exercise? Are your parks and playgrounds safe? What about healthcare access? Do you have provider availability if you're diagnosed with a particular disease? That's going to impact your outcome. If you can't get to your doctor's appointments, that's a problem. So these are called social determinants of health that are very important for us to recognize that they can impact our outcomes. So the wider set of forces and systems that shape the conditions of our daily life are the social determinants of health. And this is one representation that says about 80% of our outcomes are determined by these social determinants. Socioeconomic factors such as education, job status, your physical environment and where you live and where you worship and where you exercise and walk in your neighborhood. Health behaviors, we mentioned smoking, but also diet and exercise, which we were talking a lot about and mentioning today. Around 20% of the outcomes are based on your access to care and your quality of care. So these forces and systems include economic policies and systems, development agendas, social norms, social policies, racism, climate change, and political systems that all impact your can impact your outcome when you're diagnosed with a disease, especially pancreatitis and pancreas cancer. So we are here to help you learn and give you knowledge, learning a cleaner nutritionist lifestyle. This is the cookbook you can download. So bon appetit and enjoy a healthier lifestyle and healthier food choices. Now, pancreatic cancer does impact the entire Black community, and these are some famous African Americans who you all recognize that have passed away from pancreatic cancer. So our job here is to help prevent this from happening to those that we love. And if we do have a person that has pancreatitis or pancreas cancer, we want them to get the highest quality of healthcare available. So go to the NPF website, find the NPF Center of Excellence in Pancreatitis and Pancreas Cancer, whether that's in pediatrics or adults, and get your relative to the help that they need, where there are experts who specialize every day in taking care of patients with pancreatic disorders. This is a download, DigiReach download. So we want you to spread the word. You can download this from the website. We need you to help us and join us in the Black and African American community. Go to your churches, your community centers, your schools, go to festivals, community health fair events. You can download material. The NPF will send you material for you to have a booth or a table at a local fair to be able to spread the word and the importance of the recognition of the risk factors and the development of pancreatitis and pancreas cancer in our African American and Black community. This is just one example. This is my wife Kathy and I at a recent community health and wellness event from our Barnstable Brown Diabetes Center at the University of Kentucky. And this young lady has pancreatitis. She gave me permission to show her photo, but we gave a door prize. We gave her an award of a printed off cookbook, and she was so excited to have this because a lot of pancreatitis patients do not know what to eat. And so this cookbook is extremely helpful. This is just an example of what our table setup look like from all the literature you can get from the National Pancreas Foundation. This is our Executive Vice Chair of our health system, Mark Newman. This is one of our primary care physicians. The food connection was there, teaching you how to make nutritious, healthy meals and changing your lifestyle. These are some patients, or not patients, but subjects who were at the health fair that came by and got some literature. These are some medical students at the University of Kentucky who participated in this. So I want to challenge us, because we've been challenged by John Lewis with the following: if not us, then who? If not now, then when? So we want you to join us in this fight, in this educational effort for the Black and African American community. So I'm at the University of Kentucky. We are filling out our application right now to become a center of excellence for the NPF. We're very excited about that. We also have a marquee NCI designated cancer center where Dr. Evers is our director and professor. We can take care of, and we do take care of a lot of patients with pancreatic cancer and other malignancies associated with the pancreas. So thank you very much for allowing me to speak. Okay, so our next speaker is Dr. Alyce Adams. Dr. Adams, please turn your video, and we're excited to hear what you're going to be sharing with us. Dr. Adams is the inaugural Stanford Medicine Innovation Professor and Professor of Epidemiology and Population Health and of Medicine, as well as Associate Director for Health Equity and Community Engagement in the Stanford Cancer Institute, where she focuses on racial and socioeconomic disparities in chronic disease treatment outcomes. She'll be speaking to us today on health disparities in pancreas disease. Dr. Adams.
Thank you so much for that introduction. Again, my name is Alyce Adams. My main sort of mission in my life as a researcher and as someone who believes in community engagement is to address and hopefully eliminate disparities in chronic diseases like pancreas disease. And in particular, we would sort of try to understand what are the drivers of these disparities and how can his health systems and policymakers make different decisions. And a lot of that is informed through the research that we do. So I'm also going to be talking a little bit about research and the role that research has to play here. So specifically, I'm going to talk first about the drivers of health disparities. So I repeat a little bit of what you've heard about the social determinants of health, but really bring it into sort of the focus of pancreas disease and specifically pancreatic cancer. How do those social determinants of health result in the disparities that we see? Then I want to talk a little bit about sort of differences in healthcare access and specifically access to clinical trials in pancreatic disease and in pancreatic cancer, and sort of what does that mean? And then how do we overcome these issues and the importance, the critical importance of patient and community engagement in addressing these barriers? So first, this is just yet another rendition of what you saw previously about the structural determinants of health. As far as I'm concerned, we can't say this enough, right? So when we think about disparities, there are numerous factors that contribute to the disparities that we see. If we only focus on the healthcare context, we're going to miss other important social and structural determinants of disparities. And so it's very important to keep all of these things in mind as we think about the drivers of disparities as well as how to address them. In particular, when we think about pancreatic disease, in this case, specifically pancreatic cancer, we can sort of look at these different sort of determinants, the sort of individual determinants in terms of biology, genetics, and preferences, and how that compares to these structural determinants, some of these other factors in terms of drivers of inequities, particularly in pancreatic cancer. And there's some great work done by investigators, Knoll and Faswilla, recently in a 2019 article, some other work done by Iskander and colleagues in a 2022 article that basically lay out where some of the drivers are here of these disparities. And I think what's important to know is that while individual determinants are important, your biology, your genetics, and your preferences related to specific treatments, there's very little evidence to say that those differences drive the disparities that we see. What we do have some evidence of is there may be some differences in terms of how sort of what we call the incidence, the rate of people who have newly diagnosed disease and how that might relate to genetics or biology. There might be some differences in terms of stages of illness, in terms of when you're diagnosed, as well as individual preferences. For individuals, you have the autonomy, of course, to make specific decisions about your care. However, there's not a lot of evidence suggesting those things alone really explain the disparities that you just saw. So what does explain them? It's really these structural and systemic differences, specifically these determinants such as income, your education level, where you live, what insurance you have, what health system you have access to, your experience with the healthcare system and your trust in that healthcare system, as well as things like unconscious bias among clinicians. All of those factors seem to be the most important drivers of the disparities that we see. In what ways? Well, specifically, Blacks or African Americans are less likely to receive referrals to specialists when they're first diagnosed with pancreatic cancer. This is a critically important step in getting people the right care that they need. And yet, Blacks are consistently less likely to get those referrals. Similarly, they're less likely to get surgical intervention at an early stage of illness, which is incredibly important for the potential curing the disease. And so it's very troubling that Blacks and African Americans are consistently less likely to get surgical intervention at an early stage of disease. We're also less likely to live near hospitals that tend to do a lot of these surgeries. And so what you'll find in the healthcare system is hospitals that do a lot of these surgeries, primarily academic medical centers, the more that they do, the better they get at it. And so you see high quality care being received in settings where you have people doing a lot of these particular types of treatments on a regular basis. Yet our people are less likely to live close to those facilities and therefore less likely to take advantage of those. In addition, there's consistent evidence showing this is not just only pancreatic disease, but certainly in pancreatic cancer, that Blacks and African Americans are less likely to get the same level or dosing of chemotherapy. So if you're getting chemotherapy post-surgery, for example, we're also less likely to get a therapeutically recommended dose of chemotherapy. Finally, we're also less likely to be enrolled in clinical trials. Clinical trials are incredibly important. It's really the way that we test and understand potential new treatments and their potential to either abate the disease or improve quality of life for patients with pancreatic cancer. And the fact is we are consistently less likely to be enrolled in those trials. And so there's a few people are enrolled in trials to begin with, but when you couple that with Blacks and African Americans being even less likely to be invited even to participate in trials, this again contributes to the disparities that we see. So in terms of clinical trials, there's a number of different places where we can sort of be shut out. One is awareness. Do we even know what clinical trials are available? And that's why it's so important to connect with different groups, different patient groups, different communities, different foundations, as well as the NCI designated cancer centers to understand what trials are out there, what actively is going on in this field so that you might have access to it. Another is opportunity. Critically important here is that investigators make decisions about who's eligible for a trial, i.e. whether or not you're likely to even be asked to participate in the trial is going to depend on specific characteristics. I'm going to talk in a minute about how important those characteristics are and how that is an incredibly important bottleneck for people getting access to clinical trials and how we're trying to change that. In addition, there's issues of acceptance of clinical trials, though I will say the preponderance of evidence that I've seen in clinical trials in African Americans and Blacks specifically, it's often that once we're asked, we're equally likely to participate as anyone else. However, we're very likely not to be asked in the first place or to be considered to be ineligible for the trial for various reasons. There's also retention. What are we asking of people to do in trials? How many times do they have to come into the clinic during the clinical trial? And what does that mean in terms of their ability to actually fulfill the needs of the clinical trial if, for example, they're a working person and have other obligations and don't actually have the time or the finances, quite frankly, to pause their life in that way to participate in the trial. So eligibility criteria I just mentioned are critically important. Often what we see in clinical trials is that there are stipulations that say if you have specific chronic conditions, for example, you're ineligible to participate in the trial. Now, generally speaking, they're doing that because they want to reduce the complexity of the disease in order to assess whether or not the treatment is actually working for that patient in terms of their pancreatic cancer. But here's the problem. Many of us, especially African Americans, are highly likely to have multiple chronic conditions by the time we hit middle age. So what this graph just basically shows you is where the blue lines outweigh the red lines. It's basically saying that we're much more likely to be excluded from trials simply on the basis of having underlying conditions. So what we're trying to do is really asking trialists and really pushing trialists to reduce the number of exclusions that they have in their studies, especially if there's no clear scientific or clinical reason for doing so. And here's why. In this study by Reiner and colleagues, what they found was that with traditional criteria, Blacks consistently were more likely to be deemed ineligible for trials for pancreatic cancer relative to whites. However, if you look at the right-hand side of this graph, what you'll see actually is a narrowing of that gap between the blue and the red bars. And that narrowing of the gap was simply by adjusting the eligibility criteria to not be so restrictive on the number of chronic diseases someone can have. That step alone dramatically decreased this gap and in fact eliminated, in terms of statistical significance, the gap between whites and Blacks in terms of their eligibility. And what's great about this study was actually a simulation. So that they basically took existing studies and then said, what if they had done it differently? And then looked to see what would have happened using sort of what we call simulated patients, basically using data on people and then running it multiple times to see what would happen. And they were able to demonstrate that that one adjustment to the eligibility criteria can make a huge difference in the lives of Blacks and African Americans with pancreatic cancer. So how do we overcome all of these barriers? I just mentioned in clinical trials what we're trying to do, and certainly here at the NCI Designated Cancer Center, the Stanford Cancer Institute, led by Steve Artondi, we are now evaluating every single investigator-initiated trial to ask these questions about what's the eligibility criteria? Does it need to be so restrictive? Are you deliberately trying to include African Americans and others who may be at higher risk for the condition that you're interested in? As well, we look at the burden on patients and whether or not there's possible compensation, housing, or transportation aids that can be provided to patients in order to make their participation easier. In addition to that, what's critical here is all of you. We need patients, patient advocates, and communities to get involved with us from the very beginning. We do a lot of our work in terms of research where, researchers come up with research questions that were based on evidence and based on our knowledge, and we push them forward. But the reality is, unless we're talking to the people most affected by those conditions, those research questions may not be the best questions to be asking. So more and more, we are integrating people who have the disease as part of our research team. We have research advisors who work with us from the very beginning, even before we submit the grant, to ask the question, are we asking questions that are important and the highest priority to patients and communities around pancreatic cancer, pancreatic disease, and cancer research more generally? So in conclusion, I just want to say that access is a critical barrier to treatment and clinical trials participation. Improving access to high quality care is certainly needed, but unlikely to be enough to eliminate these disparities because of all the different points and pinch points in the system that we showed before that are driving these disparities to begin with. So really system and policy changes are also needed to drive change. Finally, and perhaps most importantly, patient and community engagement in research from the very beginning is critical for a more equitable future for people with pancreatic disease. Thank you so much. I appreciate your time today.
Thank you very much, Dr. Adams. That was just superior presentation. Looking forward to the Q&A session. It's just amazing discussion on access and the importance of what we're doing today in terms of trying to rally community engagement. Our next speaker will be Dr. Lillard. Dr. James Lillard holds a PhD and MBA and is the professor and senior associate dean for research and innovation at Morehouse School of Medicine. He is also a fellow for the American Association for the Advancement of Science fellow and National Academy of Inventors. Currently, he directs the Morehouse Comprehensive Approaches to Reimagine Health Equity Solutions Initiative, which aggregates and analyzes real-world and genomic data from African-American patients, participants in the Black Belt as one of the largest precision health initiatives of its kind. We're very excited to have Dr. Lillard here. His topic will be Personalized Medicine 101. Dr. Lillard, thank you very much for your time.
All right, thanks for having me. I've got two tough acts to follow. In the time I have, I'd like to give you a bit of background about Morehouse School of Medicine, why it's important, why precision medicine is important to us, and give you some examples of what exactly precision medicine is and some of the resources needed to make it happen. And perhaps the most important point I wanted to make, I'll try to get to at the end, and how we address fears we encounter with pancreatic cancer in particular, especially in the lack of trust sometimes, how we have to rely on faith, and what the future holds, which I'm very excited about. So Morehouse School of Medicine is in metropolitan Atlanta. They're in the heart of Georgia. At any given time, we have about 800 students. Most of those are medical doctors, but we have approaching 300 residents, over close to 4,000 alumni across the country, in particular the South. And we're a community-based medical school, meaning obviously we serve the community of patients, of students, but many of our clinical faculty practice in community clinics, community oncology settings, which, as you may know, are where 80% of cancer patients are treated. Unfortunately, I'm showing you here is an age-adjusted heat map of the United States, age-adjusted annual death rate in the United States. And you'll notice this brown coloring in certain regions, which is described also as the Black Belt. Okay, a geographic area that spans South Carolina, Georgia, where I live, Alabama, Mississippi, and Louisiana. It's where we have some of the highest incidence of many diseases, including cancer, including pancreatic cancer. And as Dr. Conwell told us, some of the highest rates are seen in African-American, highest rates of mortality are seen in African-Americans. So Morehouse School of Medicine vision is to lead the advancement and creation of health equity. And I firmly believe, as well as my colleagues, that precision medicine is a possible tool we could use to accomplish that. Precision medicine of therapies, precision prevention in terms of diagnostics to better address the health disparities we see in African Americans. Now, we're all standing on the shoulders of our ancestors, of other scientists that I work with, and unfortunately, there requires a large amount of data to make precision medicine a reality. But unfortunately, there's a lack of diversity in those data trusts, those data sets that are required to just make these new discoveries. In fact, 87% of the cases in some of the registries I'm going to show you are comprised of European Americans. And sometimes less than 5%, sometimes less than 2% are comprised of patients, participants from studies that are African American. Now, there's a number of reasons that have been alluded to. Dr. Adams told you about the social determinants of health. and when sometimes we're not even asked to participate in clinical studies like the one I'm engaged in. But another reason is just geography. If you look at some of these databases that have been around for decades, the Cancer Genome Atlas, which was started by NCI, you know, it dances around the Black Belt region. It dances around the areas that have the highest concentration of African Americans. Similarly, American Association for Cancer Research has a program called Genie. It does the same dance, as well as some private data sets or repositories where we're collecting data. So we're in the middle of this chronic disease belt, the Black Belt, and we're trying to do something about it. Now, so what is precision medicine? It's different from genetics, but it includes genetics or genomics research. And it really is perhaps best defined of health equity. And when you consider the health equity, we need to consider the entire history, the entire being of a person to provide them the best health care. So we have to have a good understanding and history of the medications they took, the type of genes that are expressed by their tissues, how they metabolize drugs, nutrition, their health records, the genomics, what I mentioned previously, where they live and the environmental factors that may influence them, the behavior, if they smoke, if they drink, do they exercise. And now we're even beginning to use social media threads to get a better idea of the type of phenotypes that these factors may all contribute to, and how we could better determine new endotypes or new diseases within diseases that we can better target and treat. Now, at Morehouse School of Medicine, we're also doing, obviously as a graduate medical school, we're creating a number of health science degrees to combat or to contribute to precision medicine. I wanted to highlight one of them that I was involved in establishing a master's degree in biotechnology. Many of you may not know that it's actually ranked number 1 or 2, depending on what survey you look at, in the country, ahead of many established schools in terms of an online program. Health informatics is another degree program that's also required for this precision medicine, as well as a number of others that I'm showing here that we're committed to create. Another important point I wanted to stress is this is a really exciting time in medicine, and there's this convergence of data science or computer science, if you will, medical sciences, social science, as we're trying to put all these pieces together. Now, there are a lot of barriers that we've encountered, frankly, as we try to implement precision medicine in our health system. And both Dr. Conwell and Dr. Adams mentioned some of these, the guidelines, some of the policies. We found that many practitioners find it difficult to navigate some of the policies the insurance may recommend in terms of who gets tested for the tests that are required to make precision medicine reality. There's also a shortage of disciplines like genetic counseling, okay? So once you get a report, this complex genetic or genomic report back, sometimes it's difficult for even the provider to make sense of it. So we're trying to do some things there. And as I mentioned before, it's an exciting time, but it's also very complex, where we're trying to stitch together literally terabytes of data, patient by patient, to make sense of that. And sometimes that data is hard to get to and difficult to structure. There's also a lack of enterprise tools or software that, say, a community oncology practice may be able to use. Now, the UK Marquis Cancer Center certainly has a number of these things, but many community-based clinics don't have these tools. And then lastly, and I hope I get a chance to get to it near the end, there's essentially a lack of trust. And it's due to some fears we have, frankly, for the healthcare system. And I'm not going to go deep into this, but these fears or lack of trust are warranted. You know, there's a long history in this country that chronicles racism and some of the implicit bias of race in healthcare. But we can address some of those things. And at Morehouse School of Medicine, we're tackling points 2 and 5, and working with partners like Invitae, where we're using things like artificial intelligence to make sense of all that massive data we're trying to crunch to find the best therapy for the patient at the right time. Now, as we synthesize this data, we're able to create, if you will, a real world evidence, real world landscape of the entire history of the patient, from maybe what happened to them at the age of 10 all the way till present time. And we're capturing things like what they were the conditions they were diagnosed with, the prescriptions they've taken over the years, the lab results, any procedures they may have, all their image data, whether it's MRI, PET CT scans, X-rays, you name it. And of course, some of their genetics that we carry out. So we're actually able to look back in time to look at the natural medical history of the individual and how they may have come to have this incidence of a disease. And then we can look forward and compare them with similar individuals going forward to see how they may respond to different therapies based on things like their genetics or their lab results, if you will. I wanted to circle back, you know, and we're also doing things, as I find the genetics make up, I believe Dr. Adams gave a statistic. It's actually it's not the majority of the factors that contribute to one's health. There's something called social determinants of health that we're capturing with surveys with participants that enroll in our studies, where we're able to determine some of the socioeconomic factors that may contribute to their care. And then after identifying those, we're actually able to intervene and provide better support, say a ride to the clinic, some health literacy programs for the patient, and even trying to modify some of the health behaviors like diet, exercise, tobacco use. And of course, and perhaps most importantly, our studies are intimately focused on proving access to some of this care, precision medicine care. Now, this is perhaps among the toughest barriers to address, and that's the lack of trust, frankly. But with trust, we're on a path to health equity. So when dealing with our patients and study participants, we have to acknowledge the fears that this has resulted in this lack of trust. As I mentioned, it's based on a number of health inequities, a number of factors that from the birth of this country through slavery, the eugenics movement in the 1900s, and frankly, some of the establishing medical practices, medical research, like the Tuskegee study that we were unfortunately the victim of. I won't go into too much detail there in the interest of time, but I've found it very important to begin to, again, one, address these fears, but have faith and hope in some of these new therapies, which I wanted to talk to you about. First, I wanted to just reiterate what we're doing with Morehouse Cares, a comprehensive approaches to reimagine health equity solutions. It's going to be one of the first community-based, multidisciplinary approach in addressing precision health. We're offering education and tools for the provider and the patient, including clinical decision support tools, free of charge tests for the patient, genetic tests, I should mention, where we're able to determine the best drug that the patient may benefit from, as well as the clinical trial they may optimally match up to that will give them the best outcomes. I think something that was not mentioned, and believe it or not, as a cancer patient, your outcomes improve when you participate, significantly improve when you participate in a clinical trial. But finding the right trial for the patient is also a challenge, which some of the tools we're providing will give our community oncology practices that we work with. As I mentioned, we're also, this isn't yet another genetic study, but in fact, we are mandated to return results to the patient and the provider so they can get the best care possible. Subsequently, as we make sense of things and through research, we're hoping to share some of these insights so we can again share additional value to the patient and the provider and health system so we can work towards a cure. Now, so the future is very bright and the future is now. In terms of precision prevention, as you may know, pancreatic cancer is difficult to diagnose. It's often, as a result, it's diagnosed often late, stage 3, 4. Fortunately, there are some technologies that have emerged that allow us to monitor circulating tumor DNA that's shed by tumors that are actually undetectable or undiagnosed, that we can then confirm by imaging and that market now. And I encourage you to work with your practitioner, your physicians to see if you're eligible. There are also, if diagnosed, there's also precision therapies. So once diagnosed, a tumor's excised or a sample's taken, we sequence and can identify factors, often mutated things that are upregulated that we can target with specialized or precision drugs to kill the cancer. Another emerging area is that of the CAR T-cell therapy, where you're taking a patient's own T cells, engineering them, expanding them, putting them back in the patient where they can go like a heat-seeking missile and destroy tumors. So again, the future is bright. I'm going to close and acknowledge the near 2,000 patients we've worked with at Grady Health System and elsewhere, as well as my staff and the physician champions that are making these studies in precision medicine possible. Thank you.
Thank you, Dr. Lear. That was an excellent discussion and really cutting edge research in regard to personalized medicine and just how technology can really help us better treat patients with pancreatic disorders and really getting into the community where our patients live. Our next speaker is Mr. Gary Lowe, and Mr. Lowe is an Atlanta native. He brings over 20 years of sales and marketing experience to the John Robert Lewis Legacy Institute, and we're just honored to have him here representing the Institute, as well as a rich background in educational leadership. He is a member of the Decatur City Schools Diversity, Equity, and Inclusion Program and the Decatur City Schools Charter Leadership Program. He has been an executive regional business specialist for over 15 years. He is firmly dedicated to the legacy of his cousin, former Congressman Lewis, who we all dearly loved. And he's committed to the mission of the John Robert Lewis Legacy Institute. We're just so honored to have you here representing your cousin and the Institute, and you're going to speak on the importance of partnerships in pancreas disease education. Gary, thank you so much.
Absolutely. Definitely a tough act to follow. But, let me first start off by saying thank you to David and the National Pancreas Foundation. I also want to thank the first pancreatic cancer survivor that I had a chance to meet, Barbara Washburn. I've said it before, I'll say it again. Thank you for being an inspiration, and thank you for everything that you do. You are the reason that I am here today. Thank you, Dr. Conwell. Like you mentioned, my name is Gary Lowe, and I'm a board of director for the John Robert Lewis Legacy Institute. People ask me all the time, what is my relation to Congressman Lewis? My grandfather and his mother were brothers and sisters. There were 4 of us that started JRLLI, short for John Robert Lewis Legacy Institute, and we've since grown to 6 in the organization. Before Congressman Lewis passed away, he left us a blueprint, a roadmap, and we felt who better to continue that legacy than his family. So born out of that roadmap was the John Robert Lewis Legacy Institute. We're a 501c3 nonprofit organization with a simple mission to promote diversity, support civil rights education, and engage in community service activities to foster the legacy of the late Congressman. We aim to strengthen communities through initiatives centered around social justice, equity in education, and health awareness. My task for tonight is to talk about the importance of partnerships, specifically MPF's African American Initiative. Partnerships are multipliers, especially as it relates to awareness. The goal is always to expand the reach. I truly believe partnership empowers individuals to act. Strategic partnerships can create more funding opportunity for research. That access to funding and resources can support community individuals to cope with and address health challenges. One of our goals in building this strategic partnership with MPF is simple: to reach more people, especially those in African American communities. We aim to build the trust by creating supportive environments and strengthening community action. Unfortunately, what took Congressman Lewis from us was pancreatic cancer, and I still get angry about it to this day. You know, he was beaten on the Edmund Pettus Bridge. He had a cracked skull, and he was left to die. And he said it many times, he thought he was going to die on the bridge. He said that he was in the biggest fight of his life when he was diagnosed with stage 4 pancreatic cancer. Along with MPF, we will continue that fight. I leave you with one of my favorite quotes from him. Do not get lost in the sea of despair. Be hopeful, be optimistic. Our struggle is not a struggle of a day, a week, a month, or a year. It is a struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble. Thank you.
Thank you, Mr. Lowe. We are just so honored to have you here with us representing your cousin and beloved Congressman Lewis. It just warms our heart to hear that his family is carrying this on, and we're happy to partner with you to continue this march. Next, we have a very special treat, and really the star of this webinar, the person that really is going to tell us how this disease really behaves, is Mrs. Zita Roberts. Miss Roberts lives in New York, but the island of St. Vincent is her home. And prior to retirement, she was a CNA and worked in nursing homes for 29 years. And we thank her for her service to that. And she was also an avid runner. Now, when she's recovering from her treatment, she enjoys spending time with family and friends and going for walks and people watching at the shopping mall and a good cup of tea. I can identify with that. She hopes her pancreatic cancer journey can help others who are going through similar experiences. And we just are so excited that you are here with us, and you're going to share with our audience and the people who are listening on the webinar. This will be shown all over the world when it hits the internet. So we're excited to have you here. And just one of the things we'd like to ask you is, about your initial signs and symptoms, and what was going on, or what did you notice that prompted you to get some help, and what kind of symptoms were you having? How were you feeling when this all started?
When I first started, I was a runner. I used to run every day. And then I start getting shortness of breath.
Mm-hmm.
And, about a week after my appetite just went.
Yeah. Yeah, so it's very interesting. So you're describing some of the things that are very common that we see, and then that is the fatigue, the lack of energy, the limitation of what we call the activities of daily living. For you, was running was part of your life, and you noticed a change in that with the shortness of breath, and the decreased appetite is also commonly seen. So these are signs and symptoms that we want people to be aware of and to recognize early on when these are happening. Can you tell us how the diagnosis was made, or how that happened, or what tests were done? What do you remember about the diagnosis?
What I remember is that I went to the hospital and they ran a lot of tests. And then about a couple of days after, they came back to me and told me, I cannot remember the tests they ran, but they came back to me and told me that I have pancreatic cancer.
Yes, and that's a diagnosis that none of us want to have, but we really appreciate your being here with us, and because there is survivorship with pancreas cancer. I personally have taken care of patients that have lived 8 to 10 years after the diagnosis, which is really amazing. And so I think your being here is a testament to your strength, and we really appreciate your taking the time to come here. Were you offered enrollment in a clinical trial that you remember at all?
Yes, doctor, I
Okay.
did.
And you enrolled in, and you participated in a clinical trial?
Yes.
Oh, that's awesome. That's awesome. Were you nervous or fearful about being enrolled in a trial in terms of just them feeling that you're going to be experimented on or something like that?
No,
Did that bother you? Okay.
Yeah, even then when I found out that I was, diagnosed, I was not fear, because I know I had a lot of faith, and I know that God is what's going to help me, and He going to help me. I wasn't in any fear whatsoever.
Yeah, I you mentioned that you had a lot of faith, and earlier what was said, feed your faith, not your fear, and so I really appreciate, we really appreciate your sharing that with us. Have you had any hurdles, any obstacles that you've experienced during this treatment that you would share with others that may have this diagnosis?
Yes, sir. I had hair loss.
Okay. Yes, hair loss. Yeah, that's important. That's important. So, any advice you would give family members, how they can be supportive, and the loved ones, what they can do if their loved one has a diagnosis of pancreas cancer? What are some of the things you can tell them that would be helpful to the patient?
Don't give up.
Don't give up.
Don't.
All right. Thank you so much. Don't give up. Awesome. Don't give
And
up.
listen,
Don't ever give up. Yes.
listen to your team members.
Okay. Great. Great. We really just appreciate your taking the time and spending this with us and just sharing your story with us. And I'm going to ask now all the panelists to turn on their video and their mics. It's time to, we're going to wrap up with a discussion, a panel discussion. And I really am just honored to be here with all of you, and I thank you for your time. It's getting later in the evening, and I understand that, and we'll move this efficiently. But I do have, there was one question I saw in the Q&A earlier, and it was about, I think it's gone now. It was about access and Dr. Lilliard, I mean, it looks like you guys are really trying to address this, and I want Dr. Adams to comment also, because one of the concepts I was introduced to in the cancer center in our breast cancer patients was the concept of financial toxicity in regard to, and I think that, and you guys both are shaking your head here, so I think this is something that we're going to see, and I want to test actually in chronic pancreatitis and pancreatic disease. I think it's real because the things are expensive and there's problems. So I think this falls under the realm of social determinants, right, of health. So Dr. Lilliard, you talked about transportation because that's a huge social determinant. I mean, what I experienced when I had patients diagnosed with pancreas cancer, they had a hard time getting on the public bus, getting to their chemo sessions, you know, and that's not easy. Most people who have a lot of means, a family member or someone is taking them, like Mrs. Roberts said, you know, your hair is falling out, you're not feeling well, you may be vomiting from your therapy and not, you know, undergoing treatment, and to be on a bus, that could be a huge barrier. So let's talk about financial toxicity and introduce our audience to what that is. And I want to hear from both of you on that because it really feeds into these social determinants of health. So Dr. Lilliard,
I may not be the best person to define some of those financial toxicities, but you know, you alluded to them. Access to the best types of testing is one that comes to mind. Access to transportation, access to some of the precision therapies I mentioned. In fact, one of the participants in our study was fortunate enough to enroll in it because he wasn't able to get testing done. His insurance wouldn't cover it completely. And fortunately, there's no cost to the patient for those studies. You know, we're working with foundations, and even some drug companies are helping to make that possible. Similarly, you know, if we identify a patient that or participant, either one actually, you know, they don't have to enroll in our study. So we want to offer that to the patient nonetheless. If they're not able to get a ride, we try to make that possible. And there are some foundations that do that now. And we're beginning to work with some faith-based groups in the future that we hope to make that even more robust solution.
Yeah, I think this is really important, you know, in terms of the access to care, right? It may be across town, and how you're going to get to it. The treatments are there, but how we get them there. So, Dr. Adams, you're in the cancer center there at Stanford. Tell us, educate us a little bit more on financial toxicity, what that is.
Absolutely. So the concept of financial toxicity is just like other side effects, anemia, neuropathy that you can have from your cancer treatment. Another side effect is the financial strain on you and your family for that treatment. And it can be the treatment itself, the cost of the pills, for example, that you may have to take, the cost of procedures you may have to go through, but it's also the things that we were just talking about in terms of how much of your work are you missing, right? How much of this is costing you in terms of, I mean, the gas prices in California right now are terrible. If you can imagine having to go back and forth 20 to 40 miles to get your cancer care, that really is going to play havoc with your pocketbook, not just in the current time, but going forward. And often what cancer centers do is that they do provide some financial relief. So here at Stanford, we have a program where anybody who gets any kind of infusion in our infusion clinics is automatically assigned to a financial navigator. These people are honestly doing God's work. They're amazing people. Their sole job is really to help these cancer patients get the care that they need. They work with them directly. They help connect them with other resources. And there are a number of different groups doing this, as we were just discussing, foundations and others. This is critically important, though. I want to point this out, is that most of this is happening for patients who are already in a clinical setting and getting care. That's usually where you talk to a caseworker, or you talk to a financial navigator. People who never make it through our doors aren't going to get that service. They may not be aware of other things that are available to them, and that breaks my heart. The idea that someone with a life-threatening condition wouldn't go get it simply because they can't afford it is wrong. And that has to do with systems and policies within our country that prioritize, quite frankly, profit over the goods of people. And so really getting involved in policy discussions, the current Inflation Reduction Act, which is now a law, is one of the first times we've ever seen in this country an effort to address price inflation related to medications because it's not based on what their value is to us as patients. It is based on any number of factors that have to do with more of the market. And so that's the first time we've seen that. And so I would say, let's see how that's going to work. See if we can leverage that for our patients. There's also a restriction on the amount of out-of-pocket our Medicare patients now have to pay for medications in particular, out of pocket every year. I believe that goes into effect in 2023, 2024. These are critically important pieces of legislation that will directly affect our cancer patients.
Yeah, thank you so much. And Mrs. Roberts, I was going to ask you a quick question here. Did you have any issues like that in terms of transportation or getting to your treatments? Can you share that with us?
Yes, I did. Many times, patient will, when I call them, they will say they are coming and they never showed up.
That's too bad. That's too bad.
It's long time before. They could come. And sometimes I have to find alternate transportation in order to get to chemo.
Yeah, yeah. And so this is the reality that we're facing. So I really appreciate your sharing that. Sharing that with us. So Mr. Lowe, I think is now not on the call, but I know they have an event, a bicycling event there in Atlanta that really it brings out a lot of people. And so these are community events where people can get involved, and a lot of medical centers, cancer centers, a lot of definitely these centers of excellence will have events surrounding pancreatitis and cancer. They help with community engagement for you to participate and get involved and be a part of the solution. And so someone has a question here, Dezita. How much did your faith and your pastor play in your role to healing? So how much did your faith and your pastor play in your role to healing?
A great deal.
A great deal.
Ambient things.
Yeah, so I being a person of faith, and I depend on it every day. And I think being positive as opposed to negative, and really having people surrounding you to help you is very important, to be encouraging. One of the things that came up was this. I'm impressed with the black belt. Mr. Lillard, you talked about, and in that belt there is a lot of lack of trust because there's history, right? And we know about the Tuskegee experiments, and so that permeates throughout our communities, generation to generation to generation. It's fresh. It's very fresh. It's not like it's many years ago. It's very fresh in our communities, and so that lack of trust in the system is real. And I'm interested to hear thoughts from our panelists in regard to that lack of trust.
Yes, I'll give it a shot first. Now, it didn't dominate our interaction with the patient. I think we're fortunate to be a historically Black medical school with providers that look like the patient, with the patient navigators look like the patient, and nurses and so on. So I think that alleviated some of the fear. But nonetheless, it was important to hit that head on, acknowledge those fears. Those fears are real. As a middle-aged Black man in America, in the South, frankly, I have some of the same fears. Right. So I think it's first important to acknowledge those, but not dwell on them. We have to move forward and explain the potential, the hope that still exists with these new therapies, with doctors like yourself, Dr. Conwell, that can really make a difference.
Yeah. Dr. Adams, any comments on that?
Just to say that I don't know how much people are aware, but the Tuskegee experiment and what was done to our people during that period of time, the report that later came out, I believe it was in 1972, someone can correct me, that really revealed what had happened and the reality and the horrors of what had happened under the name of science, dramatically and fundamentally changed the way that we do science in the world. So the Belmont report was part of that, but taking what happened at the Tuskegee experiment has had a direct impact about how we can recruit patients, our need to be honest and transparent with patients who may want to participate in trials, their ability to leave at any time. There's no requirement to participate, nor is there any requirement to stay in, even if you've initially agreed to participate. And many of those innovations and much of the growth of the clinical trials industry is because of that tragic experience. So if there's anything that I would say that came positively out of that, is it dramatically changed the responsibility that scientists have to take for making sure that we behave in ethical and transparent ways when we are conducting our science.
Yeah, I agree. That's well stated. This is really an educational campaign. We want to get the word out to everybody that we can. And I appreciate what both of you are saying. I appreciate what Mr. Lilliard said about, this, boots on the ground community centers, community access, right? We've got the big NCI designators, but what if there's a lot of people who are not at those centers, and how do we get things to them? So I really think this is very informational. I do have a question for Mrs. Faswilla Sampson, because the expertise there is promoting patient-focused educational initiatives to boost consumer awareness of personalized medicine. Any comments that you want to give us in terms of, we're trying to get the word out there, and you hear our discussion on personalized medicine. Give us some tips and pearls in terms of just really making people more aware in terms of consumer awareness.
Yeah, I'd like to say it's easy, but nothing like this is really easy.
Right.
What we actually arrived at this initiative because we held a roundtable of patients and caregivers. And one of the questions that we had posed to them was, if you had to go back again, what would you do different? Or what would you tell your best friend, your mom, your cousin about how to access personalized medicine? And what we heard, because it was varying disease states from colorectal cancer to breast cancer survivors as well, also different ages and races, that everybody sort of experiences it differently, right? It really does determine where you live, who your doctor is, what you have access to. So yeah, it's not easy. There's a lot of challenges to it.
Yeah.
But one of the things that we like to say is we've got to meet the patients where they are. And oftentimes when you're looking for information, when you get a big diagnosis, and what we'd like to do with More Than a Number is to start giving people access to information just like this and resources on various disease states, but in general, to what just personalized medicine is, and the what's coming up in the science, a lot of what Dr. Lilly put together, so that we can start to familiarize ourselves with the change in healthcare and in medicine. And we believe that doing that, along with providing some prompts, one of the educational resources we put out on our site for mtan.org was an infographic that basically asked patients questions they could ask their doctor about how to access personalized care. And just getting used to that. Patient and provider communication, that's an area that we also need to address. And it's about empowering patients to have conversations with their doctor. A lot of times we heard from patients, I feel silly if I talk to the doctor about this. They know more than me. And it's really about, no, you want to be your own advocate in your healthcare as well. So just getting people comfortable with having more conversations, and we like to say point of care conversations about their health and how to improve it, will slowly, I believe, get people more comfortable and reduce the gap in health, or increase health literacy.
Yeah, I was getting ready to say, you know, the health literacy, right? I mean, having some sessions in your community centers, in your churches, talking about, you know, what are your rights as a patient? It's okay to ask your doctor questions. It's okay to ask for your medical records, right? It's okay to see what they're saying about you in the chart, so you make sure things are accurate, so you get the right care that you need and the care that you deserve. So David is on and representing the NPF, and I just want to bring him into the conversation. David is because Mr. Lowe said something I thought was, I wrote it down. He said, partnerships are multipliers. You know, partnerships are multipliers, right? And you know, the NPF, I've been involved with the NPF when it was in the kitchen of the two people that started, the two ladies that started this. I called them on the phone, and they were running this organization out of their homes, but they were so committed to it. And look what it's grown into now. But David, tell us about the partnerships that the NPF has had and fostered over the years, and how it really is a multiplier.
It truly is. And Dr. Conwell, let me make one comment on your question. Years ago, I was in a kind of mastermind group of thought leaders, and a guy by the name of Dan Sullivan, who at the time was regarded as one of the best sales coaches in the entire country. And he talked about growing a business, but I take that in the nonprofit sector, the 3 Ps of growing an organization, and it's packaging, promotion, and partnerships. So the partnership part of it, and especially when Stock Paul and Carrie on our staff and myself and some board members kind of created the Black African American Initiative, we knew from the onset the only way we would take things to scale and really touch the tens of thousands of Blacks, African Americans that needed the education regarding this initiative with pancreas disease is through strategic partnerships. And, you know, co-hosting tonight's webinar with a Precision Medicine Coalition is a perfect example. What we've been doing over the last 6 months, meaning our staff, is really reaching out to other national and geographical nonprofits that are health related. We've been to health fairs throughout the country. We have a strategic partnerships like organizations like Black Health Matters out of the Bronx. So, you know, we just need everybody's efforts who are attending this call. And Dr. Conwell, as you stated, the follow-up will be viewed by thousands, to really contact NPF to allow us to mobilize volunteers with Black clergy, with African American churches to make presentations, to attend health fairs. But we know to get the metrics that we expect within 5 years, it's going to come truly down to strategic partnerships. So that's, I guess, my takeaway, Dr. Conwell, and to the rest of the panel. This has been a great opportunity to educate our audience of the issues facing the Black African American community regarding pancreas disease. But the call to action is really, what is the takeaway and what are the steps following this webinar? And truly it is to reach out to our office and just let us know when there's health fairs, when we can have speaker engagements throughout the country. And that's the way we're going to really impact the community that everybody on this panel and our viewers expect. So thank you for that opportunity.
Yes, I mean, thank you, David. This is the partnerships are so important. I like that statement that partnerships are multipliers. One of the things that came up for our Atlanta panelists, there's a question about how well we'll be able to provide the needed healthcare to these patients. Talking about the Atlanta population, if they are selected for clinical trials, when it appears the only health system left will be Emory. So that's a question about the whole healthcare landscape in Atlanta specifically. So who wants to take that? I'm not from Atlanta, so sounds like there's a healthcare struggle there.
Yeah, I'll that's a tough one. Now, but there are other health systems in the region, in the area. In addition to Emory, there's Northside, Health System, there's Wellstar Health System, there's Grady Health System. So there are, and more at Piedmont, there are a number of those health systems with cancer clinics where you could seek care. And we're kind of cancer center agnostic, so we'll work with all of them. We work with Emory Health System. Our study is open at Grady Health System, and and also Wellstar, I should point out. So we're making it available everywhere.
Yeah, I think that's great. Well, thank you for that. I want to just thank everyone for attending this webinar. I thank the NPF. I want to thank Elevation Oncology for sponsoring the webinar. All of you who you represent, and then the patients are going to benefit from this. Our community is going to benefit from this. I can tell you personally, I've been boots on the ground for a lot of these initiatives in colon cancer in our communities, pancreas cancer in our communities. And we started this in Lexington a couple of weeks ago at the session where I showed you, and I ran out of flyers. I ran out of pamphlets. People want this information. They want to know how to eat better. They want to know how to avoid diabetes and how to minimize obesity. So it's there for us to get the word out. And like I'm going to say it again, like Congressman Lewis said, he goes, if not us, then who? If not now, then when? And so just thank you all. Thank the NPF, all of you on the call, and our star of the show, Miss Zita Roberts. Thank you for hanging in there with us. And then, God bless you. I know you're probably not feeling well, but we just appreciate your time, your sharing, your story. This is going to help a lot of people. It's going to encourage a lot of loved ones and families. And what you said, just don't give up. Don't give up. That's what you need. And so we're going to take that message across the World Wide Web that Zita Roberts said, don't give up. That's what we're going to do. Don't give up. So thank you all again. I really appreciate spending this time with you. Looking forward to working with you some more. And let's just don't get tired. Let's don't get weary. Our people need us to educate them and get the word out. So thank you all very much. Good night and have a great evening.